Thank you very much. I hope everyone can hear me, and thank you for the honor and privilege to present what is near and dear to my heart in terms of leveling the playing field for delivery of care in all sorts of surgical disease. And this talk specifically in gallbladder disease. Okay, I have no disclosures, only that I was on the Bile Duct Injury Consensus Conference Committee and had the honor and privilege to work with our colleagues here at the panel and the table. Okay, so gallbladder disease has a disparate but universal global presence. We all know that gallbladder disease is prevalent in the United States, with the white population, the Caucasian population, being approximately about 17%. But in the indigenous American population, both in North and South America, the evidence or incidence of gallbladder disease can actually reach up to 75%, which is astounding. But gallbladder disease is also prevalent in Europe, not so much in sub-Saharan Black Africans, but in India is also highly prevalent disease. So it has a very global and universal presence, and it's something that we need to be very aware of. But the cost of an iatrogenic injury in gallbladder disease is outstanding, just amazing to me. This is a European study that looks at the bile duct, minor and major bile duct injuries and the cost to the society and the patients. But what I liked about this study is it also looked at the number of hospital days, the radiology cost, but also sick leave, the loss of productivity in the patient. So we like to think of wound infections or bile duct injuries as black marks on us, but really it's a really devastating injury to a patient who can no longer provide for their family or go to work, and the outpatient cost is astronomical. The total cost is over $1 million for a major bile duct injury, and the mean cost per patient is over $100,000. And I think we need to look at not only the cost to our healthcare system, but the real cost to the patient, which isn't usually in most of the numbers we look at. So it's something that is very serious and difficult. So when I got this talk, I'm like, well, who the heck? Why would there be a disparity in gallbladder disease? How does that happen? And I found it really hard to believe that that actually existed. So I wanted to look at some studies. There is evidence that there is a significant and important difference in disparity of care and the delivery of care in gallbladder disease. So this study was, actually I was supposed to do this on my thing where I had notes, but this study was back in Vanderbilt, I think in about 2011, 2012, looked at the urban, rural population of choledocholithiasis, the presentation and treatment, and a higher proportion of rural patients did not receive any intervention versus an urban patient for choledocholithiasis. And when those rural patients had a higher incidence of surgical intervention for common bile duct stones, it was almost always surgical and not non-operative. And you can say, oh, well, we can't help it. Those rural people, they don't have access to our panel here who can get to Morgantown and get the ERCP or the common duct exploration. It's not our fault those rural patients live there. But it is a disparity, and it is our responsibility to make sure that they do have access to the latest of care and where they are facilitated in getting into a center of excellence where ERCP and interventional radiology is available. They did not examine race or gender specifically in this study, but I have plenty of studies to help you with that. So this study is a very recent study, 2021, and again, my notes are missing, so I believe this was a Harvard-Yale study, and it looked at healthcare disparities in the management of acute cholecystitis, and they did look at the impact of race, gender, and socioeconomic status in whether a patient got a cholecystectomy or a percutaneous cholecystostomy. And again, those results were pretty amazing to me. They examined over 1.4 million patients in the national inpatient sample, and they found, of course, we know, percutaneous cholecystectomy patients had a higher comorbidity index. No kidding, they're sicker patients. But when they corrected for that comorbidity index, they statistically significantly found that male gender, Black or Asian race or ethnicity, Medicare status, urban hospital, or household income had a significant impact. Those people did not get surgery, they got a percutaneous cholecystostomy. And a significant predictor of getting a per coli with an odds ratio of over 4 was being in an urban hospital. That's kind of interesting. And there have been plenty of studies looking at why urban hospitals tend not to follow guidelines. Is that because they just have more access to IR and they're more used to calling my IR colleagues in the middle of the day and say, hey, this patient's too sick, I need you to do a per coli for me? Is it that the academic centers have a different perspective on guidelines? And that's been a question that has been raised throughout my entire career, is that academic centers may have a different, how shall we say this, mindset in returns to adhering to guidelines that are validated. Here's another study from the Hopkins University and University of Toronto looking at racial disparities in cholecystectomy for acute care admissions for gallstone pancreatitis. And this was also the same database, but a slightly earlier decade, looking at inpatient admission for acute gallstone pancreatitis and whether those patients got a cholecystectomy or an ERCP or both. And they found statistically significant evidence that cholecystectomy varied greatly by race. African Americans were less likely to receive an ERCP or a lap chole during their gallstone pancreatitis admission. And you thought, okay, well, maybe the acuity was different, maybe these were slightly different presentations, but then you would think they would at least have an ERCP, but this data held true for both an ERCP and for a lap chole. So this slide's a little busy, but this is from their study. The white bar is hard to see, but the white bar represents ERCP, the black bar cholecystectomy. And African Americans had a statistically significant less likelihood of getting any intervention whatsoever, whether that is a lap chole or an ERCP. Interestingly, Hispanics and Asian Pacific Islanders had a slightly higher incidence of surgical intervention, but African Americans had a less likely chance of getting intervention. What was interesting about this, there were other factors including influencing the disparity of care, and I just wanted to point out, you can read these yourselves, but overall the rate of lap chole post-gallstone pancreatitis was only 51%, and this may reflect a differential adherence to guidelines, and that may also contribute to the disparity in care. So what are we doing about that? Some of the things reflected in this paper looked at African Americans showing to have a lower preference for surgical intervention, and that holds true for renal transplant, cardiac disease, or knee replacements, and that's well documented. And as Dr. DeStefano said, what is the medical community doing to enhance that trust? We know with the Black American population, a lot of that goes back to the Tuskegee study, but what I didn't realize is not only were 400 Black men left untreated for syphilis, that study went until 1972. That's like my era. I was just a baby, but I was alive in that era when this study was actually going on. 1972 is not that long ago for most of us listening to this audience. So how can guidelines help address this disparity, and how can research in these guidelines help adherence to this? Well, let's look at if guidelines work. This is a study out of the Netherlands looking at the assessment of available evidence in the management of gallbladder disease. And they found only 33 guidelines existed in 2017, and only 5 of those guidelines were actually practically applicable, and up to 40% of patients never received evidence-based guidelines despite the availability of these guidelines. This is a busy slide, but I did want to let you know that, SAGES was part of this analysis, and their guidelines were included. So this paper came to some conclusions that for successful guidelines, as we've heard this talk, you need to develop an international consensus based on reasonable universal definitions using the best available evidence. Very importantly, you need to have multidisciplinary experts and endorsed by multiple international societies. And then finally, get the news out. So what has SAGES done about this? Well, SAGES did exactly that. Thanks to Dr. Demetrius here, Dr. Michael Brunt, and their tireless efforts. Believe me, I was on the end of their harassment about getting the work done on the Grade Pro. They came up with this consensus conference, state-of-the-art consensus conference on bile duct injury in 2018 in Boston. And I like to joke, and I don't have it perfectly in my notes here, but the years of wisdom are inversely proportioned to the hairlines in this picture. And you can see, Dr. DeStefano, you're not in here, so don't worry. But there's quite a bit of experience, age, and diversity in this population, and this was just taken from the back of the room. This probably combined hundreds, if not thousands of years of experience of international colleagues, I think you would agree, that came together to try to address this problem and provide guidelines to level the playing field and reduce disparity of care. And as we all know, they defined a bunch of questions, about 18 of them. They came up with 15 guidelines and provided strong recommendations. So guidelines in SAGES are not new. This is an old slide I found from the pregnancy and cholecystectomy, where pregnancy remained a relative contraindication for any laparoscopic procedures. And due to very rigorous study by the SAGES committees, and thank you to those guidelines, we now know that pregnancy is very safe, and SAGES has produced guidelines for that. So guidelines exist in other areas of SAGES that we know are true and are valid, and by the same process. Guidelines exist everywhere, whether it's for colorectal cancer, for diet, or for COVID, and we also know that they can be updated and modified, and guidelines are not rigid, but working, living tools that we need to use to monitor our actions. What is SAGES doing globally? It's now called the GLAP manual, but Dr. Ray Price, Dr. Jeff Hazy, and Linda Zhang have all put together, and also Laura Fisher, have put together the GLAP manual and have collaborated internationally with multiple institutions at multiple levels on multiple continents. We all know Ray Price's impact in Mongolia, where the open cholecystectomy rate was inversely proportional to the laparoscopic based on the time he spent there, and how this was applied throughout the entire country and how that country benefited from his heroic work. SAGES also has partnered with the Surgical Societies of Mexico to deliver standards of care and education in this area and to deliver those guidelines in a systematic and controlled fashion. SAGES also broadcasts their websites and their podcasts over to 35 countries in Latin America, Asia, and Africa. And I believe SAGES is very generous with their educational guidelines, and that's how we've addressed many of these things on a global level. So what do guidelines do for us? They provide consistency, they provide stability, they provide a frame of reference to start our surgical judgment. And in some cases, they provide blinders to the vagaries of care based on whether I'm too tired, I'm in a grumpy mood, the patient doesn't trust me or is in a grumpy mood, whether I have an unconscious bias that certainly must exist for these type of statistics to appear, what time of day it is, what time the OR is available. Guidelines help provide a frame of reference and a foundation for us to help make those decisions in a more unbiased fashion. But as in my institution, which is more acute care trauma related, they seem to push back on these guidelines, and I have to constantly remind them that guidelines don't box us in. They don't say that we have to do it this way. There are recommendations based on availability, based on patient care, and based on what I sometimes call our army. Do we have enough people in the room to handle an acute cholecystitis that looks like a disaster? Or do I need to back away because my surge tech is an ortho tech taking call on a Saturday and doesn't know the difference between a Maryland and a harmonic scalpel? And that's not the person I want to be handling a severe acute cholecystitis with. So guidelines don't box us in, but they provide us a real solid foundation to give us a chance to make decisions that eliminate internal bias based on a whole factor of issues. So I like to end with this slide. As some of you know, during this meeting, I mentored a surgeon from Azerbaijan who I asked a few weeks ago when I was writing this talk, I said, what do guidelines mean to you? Do they have any meaning for you over in Azerbaijan? And he said this, in a nutshell, in developing countries, guidelines from top societies are very remarkable to prevent inequities in surgery. Personally, I use them broadly, but to be used by more surgeons, societies must work hard to distribute them to the rest of the world. And I think that's a sort of call to leadership for SAGES to increase our activity in this area. And then I want to close with one of my favorite poets, Maya Angelou, and how this applies to our guidelines. Do the best until you know better. And when you know better, adjust the guidelines and do better. Thank you very much for your time.